Hi, everyone. My name is Carolyn Brown, and I am the Senior Associate Director for Development and Community Engagement at the Basser Center for BRCA. On behalf of the Basser Center's Young Leadership Council, I would like to welcome you to tonight's panel discussion, Navigating the World of Fertility and Family Planning. The Basser Center's Young Leadership Council is a dynamic group of 127 men and women in 27 states, Australia, and Canada, who are volunteers and supporters of the Basser Center, passionate about changing the options that currently exist for BRCA mutation carriers for generations to come. The opinions and experiences shared tonight are the panelists' own and do not represent those of the Basser Center, its Young Leadership Council, or Penn Medicine. You should consult with your healthcare team should you have any questions about the specifics of your health and medical plan. Thank you to our panelists, Drs. Haley Moss and Nicole Noyes, Danielle McKenna, and Mackenzie Dougherty, for joining us this evening for this important discussion about egg freezing, IVF, PGT, embryo banking, and hereditary disease. Lindsay Goldblatt, who will be moderating our panel this evening, is a second-year medical student at Lewis Catt School of Medicine at Temple University. Since testing positive for a BRCA1 genetic mutation 7 years ago, Lindsay has been following her passion to pursue a career in breast cancer oncology and its associated genes. Dr. Nicole Noyes is the System Chief for Reproductive Endocrinology and Infertility at Northwell Health. She is board certified in both OBGYN and reproductive endocrinology and infertility. Dr. Noyes specializes in infertility, in vitro fertilization, and egg freezing in her practice, and maintains active academic and research roles. Danielle McKenna is a genetic counselor in the Basser Center for BRCA at the University of Pennsylvania. Danielle works with people prior to genetic testing to help them understand the process, as well as helping navigate what they learn once test results are available. Dr. Haley Moss is a gynecologic oncologist at Duke University, specializing in caring for women with uterine, ovarian, cervix, and vulvovaginal cancers. On a personal level, Dr. Moss is a BRCA1 mutation carrier, which has had a profound impact on her life and her clinical interests. Mackenzie Dougherty is the Director of Communications for Autism Speaks, a nonprofit based in New York City. In March of 2019, Mackenzie was diagnosed with stage 1 triple-negative breast cancer at the age of 33 during a routine mammogram, 3 years after she tested positive for a BRCA1 genetic mutation. And with that, I'd like to turn it over to Lindsay.
Let's get started. The first question goes out to Danielle. An overarching question to set the stage for this evening is how to avoid passing down a genetic mutation that may confer high risk for developing a disease. Can you talk about how you address this with your patients?
Yeah, so I think that we never tell patients that using reproductive technology to prevent passing down a BRCA mutation is something that they must do or that they should do. We just want to make sure that they know that that technology exists, so that if that is something that they're interested in, that they can follow up and we can provide the appropriate resources at that point.
That makes sense. What are some common questions you get asked before doing that?
We get asked a lot about insurance coverage, which I think we'll probably hit today, and kind of costs of that, which as we'll get to, but a lot of times it's not covered by insurance and it can be pretty expensive. So where I talk about it the most is actually when a couple is already going through reproductive technology for another reason. They're experiencing infertility for some other reason. And since they're already going through that process, I get a lot of calls at that point that says, hey, look, I'm going through the IVF process. Can you talk to me a little bit about, what it would involve if you wanted to take that extra step? To use pre-implantation genetic testing to test the embryos for BRCA mutations. So that's when I have the more in-depth conversations with carriers in my personal experience.
Do you feel like people who you talk to know that it's even possible that they don't have to pass this down, or you kind of?
I'd say it's about 50-50. I would say about 50% of people, that's brand new information when I talk to them about it. And then about 50% of the people kind of have already heard of that or done their own research on that.
That makes All right. Next question is going to go to Dr. Noyes, unless someone else from the panel wants to chip into that. So Dr. Noyes, the concept of egg freezing has gotten more popular in recent years. Can you explain to the audience why women might want to freeze their eggs, what's involved with egg freezing, and any data on the success rates and any risks involved?
Okay. Well, I personally have been freezing eggs for women since 2004, and I've seen such a dramatic change from the beginning to now, meaning women used to sneak in to freeze their eggs, and now it's like, oh, I'm here to freeze my eggs. You know, feel very confident, very comfortable, no stigma attached. So that's a very positive experience that I've seen being on the other side of the table. Why women freeze their eggs? Well, women are born with their eggs. So your eggs are made while you're in utero, and at 20 weeks in utero, meaning halfway through your fetal life, you have the most eggs you'll ever have. So you have about 6 million eggs in utero. And by birth, you've lost 4 to 5 million of those. So you're down to 1 to 2 million at birth. Why the fetus uses all that energy to make the eggs and then most of them die out, I have no idea. I definitely would have changed the design. You know, but you say, okay, so you have 1 to 2 million at birth, and in your lifetime, you ovulate about 450. So you think, well, I've got enough, right? I'm going to ovulate from like 13 to 50. I have enough. But it turns out that you start losing more and more eggs starting at around 30, you start losing eggs, and the batch gets bigger and bigger. So from 35 to 40, you lose about 15% of your fertility potential per year. So in that 5-year span from 35 to 40, you can lose up to 2/3 of the fertility potential you had, say, at 30 or 25. So that's how women kind of get behind the 8 ball, because someone says, like my mother or anyone's mother or father, can you go to college and maybe go to graduate school, and can you travel the world and get a good job and find the right husband and have a child all before 30? Sure, no problem. You know, so that's really, I mean, all kidding aside, that's how women get into trouble, because you think, well, next year, you know, when you have so much to do on any given day, like you have best intention to do everything, and then something falls off the top at the end of the day, like you just didn't finish. And I think that's what's happened to fertility a little bit, and put women in a position where they get scared and think they're not going to be able to have a child in the time they have left. So what egg freezing does is it allows a woman to freeze the eggs at the age they are at the time of freezing, and to use it at a later age, so that you potentially have better quality eggs to use to create a child. What's involved with egg freezing is, well, first you have to make sure you're a good candidate. So depending on your age, we do a test called an ovarian reserve test, where we check to make sure that your eggs are still viable and able to be used. And that's a blood test. So I often will do it if people are just coming in to talk about egg freezing. I'll say, well, let's just get your AMH and see your anti-Müllerian hormone level, and just see where you are. See if you're, you know, are you still in a good place, or are you heading into a place where I'm thinking you're like a, you know, closer to 40 than 35, depending, no matter what your chronologic age. And if someone is a good candidate, then we generally give fertility drugs, and the drugs we have today are shots. It's something that we secrete normally in our brain. It's called FSH, follicle stimulating hormone, and it does just that. It stimulates the follicles in the ovaries to mature eggs that we can then retrieve and freeze at the age that the woman is at the time of the procedure. The monitoring process, I always tell people, they say, what's the hardest part? And I say, you know what? The hardest part of the whole thing is getting to the office for the monitoring, because we're all really busy, and you need to go in and be monitored 4 or 5 times in like a 12-day period with an ultrasound and a blood test. And that's the hardest part. And what that monitoring is for is to see when the eggs are ready to take them out. If they have to be a certain maturity to be optimal for freezing. And then when they are optimal, then we take them out using a needle through the vagina. And I know that sounds like, ugh, but it's a lot like having your blood drawn, but at the top of your vagina. So most clinics give sedation, so you don't remember or feel it. And it takes about 5 to 10 minutes. So that's not a big thing. As far as like, it's not like a surgery. It's certainly not like any surgery you would do for BRCA. And then as far as success rate, that really has 2 components. One is the age you are at the time of freezing. And the second is really how good the clinic is at freezing. So you really have to do your homework if you're going to do egg freezing, because there are all these sort of pop-up, yellow trucks driving by, things like that, that are advertising egg freezing, but you have to make sure the person that you're seeing actually knows how to freeze the eggs. Thawing isn't that hard, but freezing the eggs is pretty hard. So you have to just make sure they know what they're doing on the freeze side. But if you go to a good clinic and you're less than 35 years old at the freeze, I'd throw out a number like 40% live birth rate for a given cycle, something like that. I mean, it's really very clinic dependent. And then I think you asked about risks, and the risks are pretty minimal when it comes to doing IVF or egg freezing. And that is, if you're a very high responder to the medicine, you can get something called ovarian hyperstimulation syndrome, which is just that your ovaries get too stimulated and you can retain some water. It's pretty rare to get into trouble where you have to be admitted to the hospital or anything. And the other two risks are bleeding and infection. In my 30-year career, I've only seen 3 women get blood transfusions, and I've seen over 30,000 IVF cycles. And I don't know if I've ever admitted anyone in the last 25 years. I don't think I've ever admitted anyone for infection. So both of those are pretty rare. That was a lot of ground to cover. How was that?
What would you say is the most common side effects that you do see? I don't know. That might be a question later, but
that's a good one. I would say the biggest sort of complaint, like if women actually don't complain that much, they're in such a rush and they have so much else going on. But if they are complaining, it's because they feel bloated in their abdomen from the ovary swelling. As the ovary gets bigger, the capsule of it swells, and they actually feel that, like it feels like they've eaten too much food, like Thanksgiving around the corner. It feels like that day.
Yeah, I'm sure that's not fun, but I also would imagine that with women kind of delaying childbearing more than, back in the day, kind of like what you mentioned, are you seeing like a big uptake in your patients?
Oh, for sure. So when I first started doing this, I remember I kept track of every single patient myself in an Excel. And in the first year, there were 6 patients. And then the second year was 30 patients. And now it's like 300 and 400 patients in a year. And most women who are freezing don't have cancer or BRCA, which I have to say is taking away the stigma. It's kind of like, okay, I'm freezing my eggs. Or they'll even tell their partner they're freezing their eggs. Or even people who are partnered, even people with BRCA or breast cancer or no cancer and no BRCA, if they're partnered, will often freeze some eggs and some embryos, say, not necessarily fertilize everything to allow them to have autonomy with their own gamete in the future.
Right. So I guess that's also important to just like for our audience to separate that we can talk about IVF and fertility from someone who just wants to, has infertility issues and is not related to a genetic mutation or cancer. And then, of course, what we're going to go into later is more of the cancer diagnosis and genetic mutation and that journey. So they're kind of 2 separate journeys, both equally important.
Yeah, and I think it's interesting that, women drive IVF for sure. They're the ones always dragging their partners in if they're doing, the guy shows up and grunts basically. I hope that's not recorded. But no, the women is like, okay, I'm doing this, this, and that. And the guy says, I don't know, I'm here because my wife told me to come here. And it's really interesting to see the driving of it. But when, I lost my train of thought.
That's okay.
I know. So when women were first freezing, sorry about that. When women were first freezing their eggs, at the time, people weren't freezing embryos as like embryo banking. The only embryos that we were freezing were the extra embryos from an IVF cycle. Like say we took 10 eggs out of someone and they had 5 embryos. If we used 2, they have 3 left over, right? So that went on forever in IVF. But nobody came in as a couple and said, oh, we're both med students and we don't have time to have kids. We're going to freeze embryos for later. And then once women were egg freezing, couples started coming in and embryo freezing. So it's funny that it went backwards. And I just see it as females driving and going, I'm not going to miss this.
Yeah.
Yeah.
So another question that I think is important, especially in this discussion, is the fear that doing IVF because of, the hormones actually can increase your risk for breast or ovarian cancer. Can you talk about that?
Yeah, in fact, when we were first doing the egg freezing for cancer, people were concerned about it. I can think of one breast surgeon or breast oncologist at Memorial Sloan Kettering who was very anxious about giving even 1 week of stimulation. But really, the data has borne that it's not causing cancer. If a woman has a breast cancer, say at the time they were taking fertility drugs, definitely the fertility drugs can push it along a little bit, but it won't cause a cancer to happen. So 1 or 2 cycles of drugs are not going to cause a woman to get breast cancer. We know that for sure now.
I think that's important.
Mhm.
And is there an ideal age you suggest for patients to undergo egg freezing?
That's a good question because in, say, people who don't have a BRCA gene, like I get that question asked all the time. If I'm at like a cocktail party and a mother will say, well, my daughter's like 28, what, is this a good age? So it comes up a lot. And I would say the ideal age for freezing eggs, and I take a lot of things into consideration when I say this, is 28 to 33. Because if you're on a path, if you're 25 years old and you're already planning your wedding, you do not need to egg freeze. But if you're 28 and you're heading into residency or law school, I mean, my daughter's getting out of the military and she's 27 and she's going to do a joint JD MBA. And I said, you know what, Charlotte, you're going to freeze your eggs before you do that. Because I see that as like a 5 to 7 year path where I doubt she's going to have kids for 5 to 7 years. And I'm afraid about that. But I think for BRCA patients, like if you found out you were BRCA, the earlier you freeze, the better. Meaning if we take young donors, women who donate their eggs for older women, definitely the younger the egg, the higher the chance of pregnancy. So if you knew you were going to use the eggs, I'd say 21 to 25 is more ideal. But in the general population, I say more like 28 to 33 because not everyone needs to freeze.
Is there any danger of someone, let's say in their 40s, using eggs that they froze in their late 20s or early 30s?
Yeah, that's a really good question too. Our governing bodies in OBGYN have looked at that, and particularly the ASRM, and they moved the upper age up for what they recommend for women to conceive to 55. So we actually put embryos back until 55, where it was 50 for a long time. So the bigger risks that occur when a woman is older is, say, if she has hypertension, because that can make a pregnancy higher risk, or if she has fibroids or some other, comorbidity. We all know comorbidities now that COVID has come through. But if they have risk factors like diabetes, obesity, fibroids, things like that, then it's better to be younger. But otherwise, if you have a healthy, exercising, well-eating, rested woman, 55 is fine.
Wow. That's probably, I had no idea that you could do that.
My dad is 51 at this point, who's delivered a baby. And when I called her after she delivered, she said, I've never been happier. So that was exciting.
Yeah, those are the stories. I'm sure that makes it worth it. Although I'm sure you have plenty. Okay. So for an individual who has a hereditary mutation like BRCA1 or 2, which confer an elevated risk of several different types of cancer, are there different, do you do anything different, or do you have any special concerns in regards to their fertility and their IVF treatment?
Only in patients who have hormone sensitive tumors, which Dr. Moss is probably better to speak to that than me. But for instance, like endometrial cancers or breast cancers, we tend to add a drug that keeps the estradiol level, the estrogen hormone level, lower during the treatment, just to not push anything. But no, in general, most patients, even cancers outside of breast, do very well with the treatment.
And kind of switching gears a bit, but on that kind of same topic, can you discuss fertility preservation as it relates to someone who actually has a new cancer diagnosis, as opposed to just being a genetic mutation carrier?
A new cancer diagnosis. Okay, so sometimes when the patient shows up, they're usually deer in the headlights. They were a healthy person jogging in Central Park one day, and the next day they're told, "Oh, you have a cancer. You need surgery. You need chemo. You need blah." No, and they are just deer in the headlights. Am I going to die? And for some people are too sick to go through. Like when they show up, they're like so far to the end that it's like, and less with breast cancer, but some of the other tumors I've seen are like, no. This person's not even going to be here in 3 months. But for most people with breast cancer, there's a chance to freeze, even if they're going to receive chemotherapy as their first treatment. Usually we'll just postpone the chemotherapy for, say, 2 weeks and do the egg freezing really quickly before they start chemo. Because once the chemotherapy is in the body, we have to wait about a year. And for 20 to 25% of those people, they're going to go, have a pretty untoward reaction to the chemotherapy and not be fertile on the other side. So, that's very age dependent, but we see a lot of people 38 and 39 showing up with breast cancer. So if they're having chemotherapy first, we'll do the treatment right away. Like we just drop everything and do the fertility treatment. Usually the doctor will text me or call me and say, just go, because we want to go right to chemo. But if somebody is having surgery first, meaning say like a biopsy, a lumpectomy, or even a mastectomy, then we'll have them go ahead with their surgery. And between the surgery and chemotherapy, we can usually fit a cycle in there. So it's, I'm pretty versed in what happens with breast cancer. And so we just make it work, around the cancer treatment.
Right. So I think one of the biggest topics, and we briefly touched that we were going to talk about this, is the financial costs, because it all sounds great. Like, let's, we can all freeze our eggs and deal with it later. But realistically, that's probably not going to happen for most of us. So can you talk about some of the financial costs and if insurance covers it?
Yes. Well, so for instance, in New York, they now have a mandate for IVF, which is the first we've had ever. They did a feasibility study for a long time. It seemed like it was 10 years. It might've been 8, where they were seeing if it was the right thing to do. And now for bigger companies, meaning 100 employees or more, you have 3 cycles of IVF covered and egg freezing for cancer. So we have a big change this year in New York. More and more people have coverage for a cancer diagnosis. For instance, if your doctor tells you you have cancer and you will have a treatment that will potentially lower your fertility, then you will have coverage for the fertility preservation. That wasn't the case in 2005 to 2018, basically. Lots and lots of people did not have coverage. And it was kind of ironic. It was like, well, if your plan has IVF in it, then maybe you have egg freezing. It was sort of like this sideshow for IVF. But now I see many, many plans will say, yes, and you have egg freezing if you have cancer. The bad side to that is if you don't have cancer, say you're just a BRCA carrier, like that's something small, right? But if you're a BRCA carrier and don't have cancer, then no, you don't have cancer yet. So you might not need the treatment that will lower your fertility. So therefore we're not going to cover. I really think we have to push on that, particularly for BRCA1, because even BRCA1 patients are known to have lower ovarian reserve a lot of the time. So they just don't have the time to waste.
Yeah. So it seems like for the most part, if you have a cancer diagnosis, there's better coverage.
I would say now for me in my practice, more than 75% of people who come with cancer have coverage now, where before it was like 15%. So
does that include like state insurance?
State, you mean like Medicaid?
Like Medicaid or yeah.
Medicaid still doesn't cover. So even in the mandate this year, Medicaid and unions are exempt. Yeah.
Is there any like legislation being pushed that you know of?
I don't know about for state plans. I don't know that. I don't.
Okay, so I'm gonna go to Danielle now. So in your role as a genetic counselor, you obviously work with people who might learn or have already learned that they carry a hereditary mutation, such as BRCA1 and 2. Others also are included in these big panels, but how do you advise your patients who are considering getting genetic testing with respect to family planning?
Yeah, it's a really good question. I think it really depends on the individual. They're pretty personalized conversations. So you meet some women at 25 who are done having all of their children, and then you meet some women at 25 who haven't even given a thought to family planning, and everyone's timeline is very different. And so I really try and meet them where they are, especially if they're newly married or they have a few children already. We do just kind of straight out ask, what are your goals for family planning? Where are you in the family planning process? just to kind of get a sense of, oh, we are looking to have more children, or, you know, we're done having our children, just because that helps frame a lot of the discussions around BRCA 1 and 2 care. But, you know, we just try and meet them where they are. So if they're 25, newly diagnosed as a BRCA carrier, haven't given much thought to family planning, that's okay, right? And so we kind of try and talk about what the options are. We do talk about that, you know, there's financial expenses related to using PGT and IVF, and that it's not necessarily a guarantee at the end of the day that you're going to end up with a embryo that's unaffected by BRCA. But it really depends on the person and how many questions they have about these things, because some people are not interested at all in learning about reproductive technology options. So it really, really depends.
So, excuse me, if someone is interested, I'm going to pop back to Dr. Noyes. Can you tell us what their options are? And we commonly hear this acronym PGT, talk about what that is, and what procedures that people can do in order to stop this mutation in its tracks.
Right. So I've seen this done. Some, like what was just said, some people don't want to know anything about the embryos. They say, just make the embryos. Don't tell me anything. I'm too traumatized by the whole situation. They don't want any more information. But most people do want to test the embryos to see if they have the BRCA gene mutation. So PGT is pre-implantation genetic testing, meaning you can actually take a couple of the cells from the outside of the embryo. There's the middle part of the embryo is actually what becomes the embryo itself, and the outer cells become the placenta. And you can take some of those cells that are destined to become the placenta and test them. And it's not 100%, but it's more than 90% accurate. So it can look for the BRCA gene mutation. Now they have to get blood from the patient and actually see exactly what the mutation is, and then test the embryo. And that is expensive. That's outside of our office. That is expensive. And maybe someone else on the panel can talk about that. The embryo is that the tissue can be tested also for the chromosome complement. So most normal euploid people have 23 pair of chromosomes. So you have 22 pair, plus you have an X and an X, or an X and a Y, that is your gender determination. And so you can actually test the embryo for that chromosomal complement and see if you have what we call a euploid or normal embryo. But I will tell you, it's not perfect. So you can get some results that say something is abnormal when it's normal. It doesn't usually happen the other way. So they don't say, oh yeah, it's a perfect embryo, and it ends up being abnormal. That's pretty unusual. But they can say a perfectly normal embryo is abnormal. So they'll overread rather than underread, so we don't put back abnormal embryos mistakenly. But I've seen good embryos thrown away because of that, and that's a little bit upsetting. And I think it's also tricky because if you're not experienced in this, I mean, I've been looking at this for 30 years, so it's like I look at it and I'm very sort of like matter of fact about all the data. But if you're looking at your embryos and you see, oh, I've got a BRCA carrier that's a euploid, and I've got a BRCA negative that's a Down syndrome. You know what I mean? Like you get all these things that you weren't even thinking about, and you're like, so I've seen people get very anxious about the results. So you have to really think it through and talk to the genetic counselor about it. And there's also been people who say, test it, but don't give me the results. I don't want to know the results. And the testing can be done later. So you can actually thaw embryos out and test them at a later time. So it's not like, oh, you missed the window if you don't do it right now. So I basically don't force any of this stuff on anybody, because I feel like it's deer in the headlights, and you have to be careful how much you impose on somebody at one time with information they're not comfortable with.
Right. Another thing I feel like as a medical student, genetics gets very, very confusing. And I think, like you always hear people saying like, oh, cancer can skip a generation, or I think an important like learning point is that if you do, kind of pick your embryo that is mutation negative, let's say BRCA1 negative, that embryo, which will later become a child, cannot pass it on. So you can theoretically stop that mutation from being passed down at all, correct?
Yeah. So that's why people test most of the time. They don't want any gene mutation in the offspring. But again, then you're saying, oh, well, I would have screened myself out.
Right. Right.
the embryo, you would have been screened out. And that always feels a little weird to me when I'm counseling them.
Yeah.
Mhm.
So that was PGT. Danielle, can you talk about PGTA and PGTM?
Yeah, I think Dr. Noyes actually touched on both of those in her last explanation, but the technology, the words for the technology actually keeps changing, so it's always helpful to go over it. But PGTM, which used to be just called PGD, as in pre-implantation genetic diagnosis, they now call it PGTM, which stands for pre-implementation genetic testing for monogenic disorders. So basically that's when they're testing for hereditary conditions that are caused by mutations in one single gene. So that's like BRCA1 and 2 mutation. So if you're going to use this testing for the purposes of not passing on the mutation to future children, PGTM is what the technology that you use for that. And then PGTA is a separate test that is an additional cost. It does not come together, is when they're actually looking at the embryo's chromosomes and they're counting their chromosomes to make sure that they have 46 chromosomes. If you have missing or added chromosomes, they can cause different conditions ranging in severity. Down syndrome is one of the most commonly known conditions when you have an extra or missing chromosome. So that is called PGTA, and it does require an additional cost. Dr. Noyes covered that it's not necessarily a perfect test, but if you can ensure that the embryo has the correct number of chromosomes, then you have a higher chance of that embryo implanting and resulting in a successful pregnancy. But it's also important to keep in mind that PGTA doesn't look at all of your genes. So it's not like you're getting a whole exome or whole genome test on the embryo to look for other things like Tay-Sachs or cystic fibrosis. Like that's not going to pick that up. It's only looking at conditions that are affected by having a different number of chromosomes.
I think that's a really good point, Danielle, because I see when I'm talking to people, they get confused between their semaphore genetic testing, then what the embryo's testing. Then they think we've tested everything in the semaphore and the embryo. People get confused a lot. And so, like you said, it's a very big field. You can't just expect that if you've talked to someone for 5 minutes or even an hour, that they've absorbed all of that and say, oh yeah, I got it. This is what I want to do. It's confusing.
Yeah. And I think there's this misconception among some patients of if you're looking at the genes of the embryo, you're not looking at all of them, you're just looking at BRCA1 or 2. And so it is important to understand exactly what the options are and the different costs associated with all of the different tests as well.
Mm-hmm.
Yeah, it gets very confusing. And we spend years studying this and it barely makes sense. So I can understand from a patient perspective how overwhelming this could be. So, okay, one more question, kind of on like the logistics of what all of this is, and then we're gonna move to our patient experiences and have them talk a little bit about like personalized journeys. So are there any like contraindications or, patients that you would say this is not a good option for, we need to like see some alternative options? And if so, what are those options?
Yeah, that's really good point to bring up because, again, breast cancer doesn't usually afflict people who are 20. It can, but it's usually people who are more closer to 40 or in their 40s. And you have to make sure that their eggs are viable before you take them down the path of fertility preservation. Because, for instance, if their ovarian reserve testing is already really low, probably isn't going to buy them anything to freeze eggs that are not good quality anymore. And so you don't have to get too deep into the alternatives because it's something, again, that I said you can do until 55. But sometimes the only alternative for people are to use the eggs of another person, a younger person most of the time, like somebody who's in, say, 21 to 30, who's willing to undergo ovarian stimulation and donate their eggs. And the other thing is with breast cancer, some people don't want to get pregnant or their doctors don't want them to get pregnant, meaning carry the pregnancy. There's still some controversy about that, whether that increases their risk at all. And so a lot of times I'm talking to people about a gestational carrier, and that can get into another whole area where it's, it's just confusing and it's very difficult to decide. And so I think just knowing there are other options out there that they don't have to force themselves into something that really scares them is helpful.
Yeah, that makes sense. So we're going to move now, like I said, to kind of the patient experiences of people who have, been through this. So Dr. Moss, you and your husband did make the decision to undergo IVF and PGT to have your daughter. And if you guys recall, Dr. Moss is a BRCA1 carrier. So could you tell us why you made that decision and what it was like with respect to timing and the impact on you, both physically and mentally?
Yeah. So I found out that I had a BRCA1 mutation when I was around 22 years old, when I was a medical student at the University of Pennsylvania. At that time, the genetic counselor kind of talked to me about the options of PGD, but I was also just 21, 22 years old. And I think I maybe had just started dating my now husband. I'm not even that quite sure. But so I found out that I had a BRCA1 mutation then. And I think like maybe a few weeks later, I went and saw an REI doctor. And at that time, they sort of talked to me about the options of what happens when you have a hereditary cancer syndrome, and talked to me about PGD. But kind of like what Dr. Noyes said, I was like kind of like a deer in headlights. I was kind of just sort of terrified of the whole experience. But she did draw my anti-Mullerian hormone, which is that test that Dr. Noyes referred to sort of see how, I don't know how you describe it, how fertile you are or how healthy. I'm not exactly even sure about what it measures, but it tells you whether or not you have good egg quality or quantity, right, Dr. Noyes? Something like that. And she told
relative to age. How you're doing relative to age.
Yes, and she told me my number was incredibly low, or like not what would be expected for a 22-year-old. So here I was with a new BRCA mutation, not in a serious relationship, and also being told that I might have issues with fertility. So like, right, so there's just so much information there. And I decided to sort of just ignore the whole AMH piece and just sort of just try to live my life. And I actually did think to myself that like I might just not be able to have children. So here I am with a BRCA mutation, and maybe I'm just not fertile and I'm not going to have kids. And I think sort of at my 6-month date-anniversary with my husband, I like sat down with him and I was like, I have this BRCA mutation and I'm infertile. Like I essentially told him both of these things. And I was like, and so I'm giving you sort of the out that you could just sort of decide that you don't want to date me or be with me anymore. And he decided to just stick with it and be with me, knowing that I might have all of these issues. That was probably when we were around like 23, 24 years old. And then at that point, I was graduating medical school around 26, and I started NYU for residency. I was still with my partner at the time, and we got married when I was around 28. And we kind of always knew that we were going to go down this path of PGD. I kind of was pretty clear with my husband that I come from just tons of generations of women who have had breast cancer, and several of whom had passed away. And I think for me, knowing that technology existed, it was just too like, this is just like a no-brainer. And I don't feel that way now. And I don't want to sort of say that this is a no-brainer, because it's very like an individual decision for every single person. And me as a GYN oncologist, I bring it up to my patients sort of that, like, this is a decision that you make. There's no right or wrong decision. It's whatever you think, what's whatever right for you and your partner. But for me, it was just kind of like, I'm an OBGYN. I have the resources to do this, and that's huge. I had the resources. It was very costly, and sort of we'll talk about that in a few moments. But I kind of got married to my husband when I was 29, and I said, we're doing PGD this year, knowing that I did not want to have children, because I was about to start fellowship, a really hard surgical fellowship in oncology, and I did not want to have kids then. So this was around 2015. I started my first cycle, and we'll sort of talk about the pros and cons of learning about whether or not the embryos have a BRCA mutation. I did it. The odds were not in my favor. I got 6 embryos. All of them had a BRCA mutation. And then I did it twice more. And that was hard. I mean, I was a resident. I was working 80 hours per week. I was on night float, going from the hospital to Dr. Noyes' office, getting ultrasounds regularly. But ultimately I have no regrets. In terms of side effects, I felt a little bloated. I was constipated after the retrieval, but really, like, with someone who was working constantly throughout it all, I never had weekends off. I took a day off for my retrieval and went back to work the next day. It didn't really impact my life that much in terms of side effects and complications.
That's good to know. Thank you for sharing that journey. So I want to ask Mackenzie how your journey differed from Dr. Moss, and if you could speak a little bit about that.
Yeah, absolutely. So I found out I was BRCA positive the spring of 2016. So I was 30. I was single. I was kind of going through some personal issues with a sick father. Work was a little up in the air. So it was definitely egg freezing at that point was definitely a priority for me, but I just wasn't there financially or emotionally to tackle it. So once my life definitely settled down a year later, I had the scheduling flexibility to take it on. For me, the process as a single woman was so liberating. Just knowing I had this mutation, knowing that like I was really trying to put an insurance on motherhood for me. And it's like Haley said about, you're dating someone and you kind of share this news. I mean, I went through plenty of guys who I would share the news and it was like, you never heard from them again. It's a lot of baggage there. So for me, the process was it was very, it made me feel so strong, and it gave me a lot of courage. The process itself, it was definitely intimidating to deal with, and the shots are a lot, but I really was able to get in the groove. I luckily had an office that was nearby that was like 5 minutes from my apartment. So the ultrasounds and the blood work was nothing really too crazy for me. And it was smooth sailing, to be honest. The hardest part for me ended up being afterwards, because I had really disappointing results. And the doctor just didn't know why. So all I had were 4 mature eggs, and there was no explanation for it. And really it hurt a lot. That made me just walk away from that. And we'll get into the cost of it, but that was a whole other reason where I was like, I can't do this again financially. So it really had to be something I had to walk away from. Fast forward 2 years later, I was 33. I was dating my now fiance, and, suddenly diagnosed with stage 1 triple negative breast cancer. And when I say suddenly, obviously I knew it was something there, and it was something that was always a possibility. It was during one of my screenings. And this time around, the egg freezing was obviously a completely different type of experience. Luckily, I had the experience of doing it before, that I knew what I was getting into. And yes, I probably walked in like a deer in headlights, but at the same time, I had that knowledge of, I know what this is going to be like. If anything, what I really need to make sure is that this is a speedy process, because I need to get my double mastectomy in, 3 weeks at the latest. And you this sounds awful, but there's such a different rapport with your team when you're dealing with it from the BRCA1 side, and then when you're dealing it from like the actual breast cancer side, it's a little bit more like, okay, we need to like handhold you, we need to be a little bit more gentle, but at the same time, we really need to get to business. So yeah, ultimately my body responded so I had a retrieval before my double mastectomy, and then after my surgery, before chemo. And we ended up doing, my fiance and I, we went for embryos. So my body responded the same way. I had 4 mature eggs the second time, 1 embryo. And then actually the third time, again, my body had 4 mature eggs and 0 embryos, which wasn't surprising, just given everything going on with my body already. I just think the stress was there. But we decided not to do PGT yet, which I know it's an option to do it after. And honestly, it's so funny and timely having this conversation, because I'm getting ready to go see my doctor again to get my AMH tested and, get my ultrasound this coming week on Wednesday. So, hopefully I'll be able to go through it all over again. Like, that's the thing. At the end of the day, we're so lucky that science has gotten to this point where my oncologist, and I'm not ready yet. I need another year of remission at least before I can actually start to, have children, but I'm going to do my best to try and preserve what's ever left while I have the time waiting. So just trying to make the best use of time.
I also just want to say that people will have opinions no matter what. I mean, including my mother, who thought it was like absolutely crazy that I was spending so much money. And I mean, it was a stressful experience going through 3 cycles and not having a lot of BRCA negative embryos. I mean, I think that there is a lot of disappointment, but there's a lot of like joy in the process. I didn't really go into it, but I did my embryo transfers in 2015. I did my retrievals in 2015, wanted to finish my medical training, and then implanted a BRCA negative embryo in January of 2019. And now I have a 13-month-old. And I remember when she was born, I'm gonna like get we didn't know if she was going to be a boy or a girl. We actually thought she was going to be a boy because we had a lot of boy embryos. But we asked them to just implant whatever. And I remember when she was born, like the first thing I said to my husband was that she's the first female in my family that doesn't have a BRCA mutation. And to me, like that was just like huge. And again, my mom's still going back on it. She goes, I still wouldn't do it because then I wouldn't have you, and you've brought me so much joy in my life. And that's true. And I think that that's why this is a very individual decision. And a BRCA mutation is not like cystic fibrosis or other diseases where really truly can potentially shorten your lifespan, and there's very little quality of life. Cystic fibrosis has obviously changed a lot in the last 2 decades, but again, my mom would tell me that this was not the right decision. I spent a lot of money on it, but to me, like what a blessing that it was for me.
So thank you both for sharing those like super personal journeys. And I want to like hash out some terminology, because I think it just can get confusing. Like we're talking about, and I will direct this to Dr. Noyes. Can you just briefly, like how egg freezing is different than egg freezing with fertilization and implantation? So we saw that Mackenzie is freezing her eggs for an eventual implantation, and Dr. Moss did the egg freezing, or I'm not exactly sure. Did you do the egg freezing?
I did embryo freezing.
Okay, so can we talk a little bit about those differences? Because even myself, I'm getting a little bit confused with those 2 processes.
Yeah, no, I think that's a very good point, because people do get confused, because when you think about traditional pregnancy, it's basically conjugal relations in a bed that then result in a child. And you don't really think about it. It's just like, okay, egg, sperm, embryo, baby. But that's not how it works in a fertility clinic. And even though I joked that, men come in and grunt, that's about like leaving their semen analysis. In fact, what I've seen when people have BRCA or cancer, in a lot of ways, the men are more afraid, because they're thinking, I don't want anything to happen to my significant other here. Like anything you're going to do that's going to risk them, I don't want them to do it. They're more concerned about the woman sitting next to them than they are about having a baby, where the woman's like, I want the baby. So it's been a very interesting journey to see that, how protective the men have often been about the women. But getting into like what they do. So when we stimulate the ovaries, it's the same no matter what your end product is going to be. So in order to get eggs out of a woman, you have to stimulate the ovaries to mature more than 1 egg, and then you retrieve those eggs out of the body. And once those eggs are in a dish, you can either take them out of the dish and freeze them and put them in the liquid nitrogen for storage, or you can add sperm to them a couple of hours after you take them out. So literally the same day we take them out, we add sperm if you're going to create embryos. And then you can freeze embryos at any stage. You can freeze them the day after you fertilize them. You can grow them for 5 days. You can test them or not test them before you freeze them. You can freeze them, take them out of the freezer later and test them later. So there's lots of options along the way. And I've had women take their eggs out of the freezer, add sperm, and put them back in the tank as embryos. Like maybe they froze eggs when they were single, and then they have a significant other and they're like, no, like what Haley was saying there, I only want to put back a BRCA negative embryo. So I'm going to actually take my eggs out of the freezer, fertilize them, biopsy them, put them back in the freezer, and find out if I have a BRCA negative. So that's all possible. And it's really a matter of being very patient with the patient. Sometimes it's more than one consult. It's often 2 or 3 consults where you're really explaining them. They go home and Google like crazy and up their own education about something, and then come back and ask you questions, and you make sure they have a good understanding, because people do get confused about what's an embryo, what's an egg. And the only thing you can put into the uterus is an embryo. So in the early days, back in the 80s, we could do gift and zift, where we'd actually put, gift is where you actually put the sperm and egg into the fallopian tube. We'd actually cut the woman in the belly button, get into their fallopian tube, and put sperm and egg into the fallopian tube. And for the Catholic Church, that was the only thing they allowed. But now we haven't done gift for a really long time. I don't think anyone in the US is doing it since like 1995. I don't think anyone's doing it. So if you're putting something into the uterus, it has to be fertilized at this point. So you'd have to create an embryo with egg and sperm at this point. I hope that's helpful.
Yes, thank you for clarifying. So I want to get to, if any of the audience, if you have questions at all, start putting your questions into the chat, and then we can read through those. But before I start asking your questions, I just want to do, kind of ask the panelists, the elephant in the room, about the insurance coverage, the hidden costs, the real costs. Are there any options to subsidize these costs?
Yeah, so my first cycle when pre-cancer, mutation wise, that was the hardest part of the process, was having the awkward calls with the insurance company, trying to explain to a really sweet person on the phone what a mutation is and what BRCA1 is, because it was a lot of educating who you're on the phone with to get them to understand, so that they can set you up with the next person that you need to talk to really fight for your coverage. So I think the longest part of my process was really making my claim and getting it through. And then even when they said like, okay, yeah, we will cover 80%, 20% out of pocket, that seems like, oh my gosh, this is incredible. And they're like, yeah, but you never know, once the claim goes through, like it might not, we might not cover it, which is crazy, but that is the world we live in. That is health insurance. But the other part of the cost that Dr. Noyes can probably speak to it more better is the actual fertility drugs that you have to take. That is a whole other expense that really comes into play. It came into play more so my first time, because then when I went in as a cancer patient, my insurance covered all of my outside of the medicine, and then luckily my office actually collects extra medicine, which I know this sounds kind of like weird, but ultimately they'll collect extra drugs that don't get used by other women, and then they'll save them for special circumstances where someone, can't afford their medicine, or is like me in a situation where there's cancer involved and it's underneath a tighter timeline. So for me, like it's crazy how much you have to work to get that coverage. And I was able to get it, which I'm so lucky the first time, and then obviously the second time, but still now it's like something that I have no idea if I can get covered if I go back to do another freezing, and what that's going to be like, even though I'm still in the same boat. You ultimately have like a lifetime cap in my situation, which I believe I already hit, but at this point it's just might have to be something that I do out of pocket, just to be able to get that extra sense of security.
Yeah, I think that's a very good explanation. I think also most clinics that deal with patients that have BRCA or cancers have a different rate. Like we have a special rate, kind of like, Bloomingdale's Friends and Family. We have a much lower rate. There's no money being made on cancer patients in our clinic. So we make it the rock bottom price that it costs us to do it. But you're right, the drugs are very expensive. And some of the drug companies, like Serono is one of the companies that makes it, and Ferring. And so there's a couple of the big companies that make it. And they have programs for patients with cancer where they'll get you the drug, the Live Strong and Fertile Hope. But not everyone qualifies. And I've had to fight sometimes for the like BRCA patients. If they don't have a cancer yet, they're like, well, I don't know. But you can kind of push on that a little bit. But the drugs are a big part of it. The drugs can cost $4,000 or $5,000 just for one cycle. So that's something that should definitely be covered. It should be a more regulated situation and something that's mandated. I think we can push harder, particularly for BRCA1 patients, because they do have this associated lower ovarian reserve with the BRCA gene. And so, I think the time is really ripe to deal with that now, as more and more companies are covering even egg freezing for their healthy, non-BRCA carriers. Like Facebook and Google have egg freezing, and even Northwell Health gives 3 cycles of egg freezing to their employees. So more and more companies are covering egg freezing to keep their younger patients active and working. I think they're hoping if they freeze some eggs, they'll work a little bit longer without having a child. And I just think it's time to push for that for BRCA1 and hopefully BRCA2 patients.
Yeah, so Livestrong, even though I didn't have a cancer diagnosis, paid for my meds. At the time, I was an employee at NYU, and they covered your first IVF cycle. Then, so my second and third, I paid out of pocket for, but I did pay at a discount because it was for the indication wasn't exactly infertility. But where I am now, you have to work at Duke for 2 years in order to get any infertility coverage. So it really depends on who your employer is. But I do just want to make sure that like people are really aware of all of the hidden costs that, even I'm saying this as a doctor, like we're like incredibly naive to all of the different line item things when a patient gets surgery or gets chemo or gets whatever procedure. And so there are several costs that I kind of were surprised by, and maybe Dr. Noyes can sort of explain like why it was indicated, but clearly I had to pay, it wasn't through your doctor for the probe in order to do the genetic testing. So they like got my mutation, was able to make a genetic probe to sort of match it to the embryo to see if the embryo had that mutation. And for me, and again, this is in 2015, and I've talked to Dr. Noyes about it. I think a lot has changed in terms of the cost of these probes, but I spent over $20,000 out of pocket for those probes. And then in terms of the IVF itself, I had to pay for ICSI, which Dr. Noyes can explain it a little bit better, but essentially where they look for like one healthy sperm from the sperm donor or your partner to implant it into the egg. And that was quite costly. And that I did not, and I still to this day don't really understand why that was done, because my husband doesn't have any issues with infertility. And so like that was like another line item thing that I had to pay out of pocket for, and I was a little surprised by. And now even doing like the embryo transfers, my insurance didn't cover the embryo transfers, which are around like $4,000+ and then the anesthesia fees for when you get these procedures. So it all like there's a lot of surprise line items, and I think the good thing about something like this is sort of you can go into it knowing that there are all these like secret fees, and to sort of keep track of it. A lot of them you can't get out of. I tried to get out of the ICSI because I like didn't understand it from a medical reason, and I lost that battle. You tend to lose the battles, but it's important just to be aware of it, because I think I went into it as a medical student thinking like, what is this going to be like $15,000? And I think my husband and I probably spent over $30,000 to $40,000 on it at the end of the day.
Wow. Yeah, the ICSI thing is funny because I don't make people do ICSI where I am. And that was more the genetic lab itself would say, well, we don't want the extra DNA around from the other sperm that will be there around the embryo. So they just thought it was a cleaner testing ground for the BRCA gene. So that was a push from the genetics lab. And also all those costs you were talking about with the probe, that's all coming from the genetics lab, not even the doctor's office. And so even as the doctor, I don't even know what the patient's paying. We'll just say, okay, well, the genetics lab wants you to have a probe made. And then I don't see the patient for a couple months, and then they come back and cycle. And they never say, wow, that probe was really expensive. And you're one of the first people who's ever said that to me, maybe 2 or 3 other people total. Like they don't even address it with me because it's sort of like this outside cost. But I agree with you. That all should be covered.
I think another unexpected cost that I learned about from doing another one of these panels is just the storage fee. So just to store it per year was like $1,000-ish, give or take. So if you do it at 25, you don't need them until you're 35. That's $10,000 just.
Yeah. So I'm a physician at Duke, so I live in North Carolina, but I'm from New York, and I did all of my my egg retrievals and embryos in New York City. And so my husband and I have a joke every like 6 months when we pay our apartment on on the east side of Manhattan for our embryo transfers. because we've been paying that bill also every 6 months.
Yeah, that's interesting because when I moved to Northwell, I actually lowered the price of storage and it's lower for patients who have cancer. So we sort of changed things around. Like I was able to change a lot.
All right, so I want to get to our Q&A because we have a lot of questions in the chat. I'm just going to read them and then I'll let you guys kind of decide who you think is best to answer this. So our first question is it possible to do PGT on an oocyte or is it only done on an embryo?
That's a very good question. We used to try to do PGTA testing from polar body, which is the piece of the chromosomes that gets kicked out when the egg is mature. But no, you can't do the PGTA on an egg. It has to be an embryo at this point.
Next question is there a risk of damage in the thawing and refreezing process? I have several frozen embryos from IVF immediately prior to chemo. I only did PGTA because I was unaware of PGTM.
That's a hard thing to answer in a quick sentence, but I would say it's like a risk-benefit ratio. If the information is worth it to you, I think it's worth it to do it. The small thing I worry about with all of IVF is something called epigenetics, where every time you do something to the embryo, you could perturb its overall competence. But no, a lot of people thaw their embryos and put them back in the freezer. That's a very common thing that we do.
This is an interesting question about how COVID has impacted this process. Or has it not?
For me, it hasn't. We closed for 2 months. We closed from March 18th to May 15th, but otherwise it hasn't impacted anything.
So I'm assuming with like a cancer diagnosis, you know, you can't not go get treatment because of COVID, but with someone who's just interested in egg freezing for the distant future, were they still able to get appointments?
Yeah. New York, fertility was considered essential.
That's good. I guess that's state run, so I'm sure it's different other places. All right, next question is how important are uterine tubes during pregnancy? If BRCA1 carriers like myself have already gotten prophylactic bilateral salpingectomy with delayed oophorectomy, are IVF pregnancies still possible?
I think with uterine tubes, you mean fallopian tubes. Fallopian tubes, you can completely get pregnant without your fallopian tubes. Not to worry.
Okay, next question is, for women who have been through chemo already, do you use a difference in the euploidy rate? Do you see a difference in the euploidy rates? In other words, does chemo age eggs or reduce egg quality even years after chemo is over?
That's a very good question. So in fact, it does. So women who have had strong chemo where it's pushing their ovaries toward menopause definitely have more what we call aneuploidy, meaning non-euploid embryos after chemotherapy. Definitely we see that. Like it's like an older egg.
Are there certain chemos that are more associated with that?
The Cytoxan is probably the biggest culprit.
All right. How long does it usually take to have several kids with IVF? We always planned to have a big family before my husband found out he is a BRCA1 carrier. Other than that, we are both healthy and in our early 20s.
Well, it depends. So if a woman has BRCA1, they tend to make not that many embryos. But if it's the male partner in this case, then the woman, if she's young, should make a good number of embryos. And you can often get a whole family from one batch of embryos that you create at one time. And when you decide to come back, it depends on whether you have a C-section or a vaginal delivery. With a C-section, you have to wait longer. But you could definitely have, say, 3 kids in 6 years with a batch of embryos without difficulty.
Okay. Can you talk a little bit about doing PGT for other cancer risk genes, CHEK2, ATM? If the variant is more of a moderate or low risk gene, how does this change, if at all, the conversation with the patients? I think that's a really interesting question.
I think that's for Danielle.
So I would say I don't go into it in as much detail with people who have low or moderate risk genes. That's a complicated question because ATM especially has a separate kind of condition associated with it if both partners are ATM carriers. So that's where I talk more about family planning with some of those genes. I've talked to some of my colleagues who work at these genetic testing labs who create embryos, and they do say that they see people coming in for genes that I would consider to be pretty low risk of cancer, like 10% lifetime risk of cancer, for like colon cancer, for example. And that there's a lot of ethical things to consider when you're using PGT for something like that. But I definitely don't go into it in as much detail with some of the lower risk genes as I do with BRCA1 and BRCA2.
I just saw a patient with a BRIP1 mutation, which is, again, the lifetime risk of ovarian cancer till the age of 80 is probably between like 5 to 7%, something around that. And I mentioned it to her because, I mean, the technology exists, and I personally think it's important for patients just to be aware of it.
Yeah, that's usually what I leave it at. Like, this exists. If you want to know more, let me know, and then we can talk more about it.
Okay. Can PGD be accomplished at the time of egg retrieval, or is PGD done just before implantation?
Oh no, it's definitely done at the time of the egg retrieval. So once the eggs are taken out and placed with sperm, you grow them for 5 days or sometimes 6 days until it reaches what we call the blastocyst stage, where the embryo has differentiated into what will become the embryo and what will become the placenta. There's actually two, like there's a round outer group of cells that is called the trophectoderm, which becomes the placenta. And once you have that, that's when you do the biopsy, and then you put the embryo in the freezer, because it takes sometimes up to 2 weeks to get the results back from the biopsy. So the embryo will be in the, in the liquid nitrogen while we wait for the results.
I'm going to skip down just to piggyback off of that. Does storage of like an embryo or just an egg, does that decrease viability at any point?
No, but the freezing process for the egg, it's pretty extreme to freeze the egg because it has a lot of very important proteins and things that help with bringing sperm and egg chromosomes together. The meiotic spindle, if you remember, is what brings the chromosomes together. And so we do see a lower, what we call blastocyst formation rate, those embryos that will make it to that 5th day from frozen thawed eggs than we do from fresh eggs, just because it's a lot for the egg to go through. So the yield from a frozen egg to make it to blastocyst is lower than a fresh egg.
Okay.
But no, they don't degrade in the freezer like the food you have in residency where it's been in there 4 months.
Freezer burn.
Freezer burn, you're like, probably not, right?
Doesn't taste as good. Okay. How are we as patients able to research and be discerning about which clinics or facilities are good at the freezing process? Do we simply ask them directly, or is there any kind of reputation reviewing body with public data available?
That's a really, really good question, because we have data called SART, S-A-R-T, the Society for Assisted Reproductive Technology. But for a lay person to ferret through that and figure out which are egg freeze and which are thaws and which are cancer, it's almost impossible for you to figure that out. So you really have to get it from word of mouth. Like, how many thaws have you done? Not how many freezes have you done? How many thaws have you done that resulted in children? So that's a very good question to ask. If you go, okay, well, how many freezes have you done at this clinic? And they go, 1,000. Okay, how many thaws have you done? If you get E.F. Hutton, well, we actually haven't thawed anything yet. Okay, I would look around.
That's a good point.
Well, because the lag from freezing to thawing is often 4 to 5 years. So you could freeze a lot of eggs in 4 to 5 years and never having thawed them.
Right. Okay, a few more. What is the probability of a live birth per stored embryo?
Oh, per each embryo that's stored? I think that per embryo live birth rate right now is running at about 7 to 10% for one, if you only have one embryo stored. But when we put a good embryo back into the uterus, meaning it's euploid or, it got a grade A rating, like we literally give them it's a beauty contest under the microscope. It's not exactly a bathing suit, but it gets a good rating. Then one embryo can give you a 50% chance of pregnancy if the woman is young enough. So that's an age dependent number. So if you get to like 40, it's about a 30% chance of pregnancy, where if you're 35, it's about a 40%. And if you're 30, it's 50%. It gets better and better as you get younger because the age of the egg is younger. And that's by the egg age, not the age you are when you put it back in.
Mm-hmm.
So I think a round number is like 40 to 50% if you were throwing a number out once you put a good quality embryo into the uterus. But if you're looking at each individual embryo that's out there, it's about 7 to 10% per embryo that's in the freezer.
Okay. All right. One last question, well, two. I'll go quick because I know we're kind of nearing the end. Is there any organization leading the fight for insurance companies to pay for positive BRCA, but not cancer?
We should.
Yeah. We'll get started on that.
A writer in the audience, we should write something and do it at a state level first and then go, then try to go bigger.
Yeah. Okay. Last one, and then we'll wrap up. What's the latest technology for freezing, storing, tracking, and managing eggs and embryos?
I don't know what that question means.
I'm assuming it means like, are there big databases of like these patients that exists and where the eggs are and how many they have? And I'm assuming that's what I got from the question. I don't
have a good national registry for, say, egg thaw and egg storage for BRCA and cancer. There isn't one, unfortunately.
Okay. All right. So I think that wraps up the Q&A. Are there any final thoughts from the panelists or the audience before we end this?
I just want to say, for me personally, I'm honored to be part of this. I think the fact that so many women signed up and that people were so brave telling their stories it's just an honor to be part of this. Thank you.
Also, I just want to tell patients to talk to their doctors about this technology. I mean, I think when I'm in a room with GYN oncologists, doctors who sort of specialize in caring for women with BRCA mutations, a lot of them have never heard of this. Like, they were like in disbelief when I've mentioned it to them. And so, I mean, you have a lot of information that your doctors don't have. And so I like sort of challenge you to sort of talk to your doctors and say that, I went to this panel, what do you think about this? And you might be teaching them more than you know.
Mm-hmm.
I would just say to keep in mind that this is a really, really personal choice. There are cheaper and more fun ways to have babies. But on the other hand, this is a wonderful technology that exists. So don't ever feel pressured like everyone's doing one thing or the other. It's a really personal choice.
Mm-hmm. Absolutely. And also just something to think about also is like the emotion of all of it. And, it's okay to, feel all the feelings. I mean, I feel like we talked a lot about the physical and financial side effects of things, but there's definitely a lot of emotion involved in it. And it's a process.
Yeah. In fact, one of my consults today was somebody I talked to. She had colon cancer. And the first time I talked to her, she was going into her colon surgery and she thought she was going to be freezing after. And it turned out they had to take both ovaries and her uterus out at the time of surgery. So now today the consult was about her surgical menopause, that she woke up in menopause and how she can't sleep. And so she feels very anxious. And, you just have to be there every step of the way. I mean, just watching how distraught she was over her current situation and just being there for her. Yeah. And you don't have to be a doctor to be there for someone. Just anybody can be there. Your friend, your mother, anybody, your partner. Really important, because doing this alone is really scary.
I also want to say thank you. I'm almost embarrassed that I'm a fourth year medical student and a BRCA1 carrier, and I honestly didn't know 90% of this. Now I'm like, I got to go make an appointment with Dr. Noyes and freeze my eggs. And thanks, Mom, for paying for that. Because, and I'm pretty sure she's on here. There was just so much I didn't know. And that's coming from someone who is supposed to have like all this knowledge and access. And I didn't know that. So I want to thank all of you for sharing your stories and your experiences, because, I'm sure everybody on here needed it.
Yeah, it's amazing how many women that are my age say to me, my daughter is 30 or 32. Amazing how many mothers are out there hoping their daughters freeze, which is very interesting to me.
Yeah.
Good. It's progressive.
Well, thank you again, everyone, for joining us. Thank you to our incredible panelists. Thank you, Lindsay, for moderating. If anyone is interested in learning more about the Basser Center's Young Leadership Council, please send me an email, brownca@upenn.edu. Thank you again, everyone, and have a great night.